Okay, hello everyone. Guten Morgen. I'm Ayu Asakage, currently a researcher of INSERM in France and an emergency doctor in Japan. So, ich komme aus Japan. So, I'd like to thank you for giving me the chance to speak here today at the end of my research journey in Europe. And thank to Professor Mevatsa and Dr. Dunio for mentoring me. So now my presentation is the association between PaO2 levels and mortality in severely ill patients. While the oxygen is essential for the maintenance of biological functions, it has also been noted to be toxic. FiO2 and PaO2 have been shown to exert the toxicity through different mechanisms, and especially in the patient who admitted to the ICU often receive supplemental oxygen with high FiO2, leading to high PaO2. However, clinical practice guidelines give no recommendation for oxidation targets in adult patients in the ICU due to lack of evidence. So recently, extremely high PaO2 was reported that's more harmful with the U-shaped curve, and it was also reported that the too high PaO2 levels does not improve patient outcome. And in a research comparing high and low FiO2, there is no significant difference in 6 months mortality nor biomarker concentrations. So our current studies was designed to examine the toxicity of PaO2 and FiO2 in the entire ICU patient population. And it's based on the FROG ICU cohort, multi-center prospective observational studies, and we set the primary outcome as 28-day all-cause mortality and secondary outcome as 90-day all-cause mortality. And we analyzed these three inflammatory biomarkers, IL-6, adrenomyosin, and DPP3, to determine the relationship between oxygen and inflammation leading to the tissue damage. So these are the survival curves for 28-day and 90-day all-cause mortality. And we divided the patient in two groups using the mean values of PaO2 or FiO2 during first 3 days. And the hyperoxemia group had a lower hazard ratio than normal oxemia for both 28-day and 90-day all-cause mortality. On the other hand, high FiO2 had high hazard ratio than low FiO2 for just 90-day all-cause mortality. To add information on the tissue damage by PaO2 or FiO2 through inflammation, we verified that the correlation of PaO2 and FiO2 with these three inflammatory biomarkers, IL-6, adrenomyosin, and DPP3. Overall, they negatively correlated with PaO2, while positively correlated FiO2. However, all of these correlations were significant but very weak. So our current analysis has demonstrated that hyperoxemia had lower mortality than normal oxemia, and high FiO2 had higher 90-day mortality than low FiO2. Concerning first point, it is possible that normal oxemia had more severe condition than hyperoxemia, therefore PaO2 remained lower, Because in FROG ICU, the patient were not initially assigned to normal oxemia or hyperoxemia. I mean that it's not strategy is just only the result of treatment or their status. So the mortality risk might be lower in hyperoxemia than in normoxemia. Secondly, with these two findings, we might estimate that high PaO2 leads to worse outcome by being more likely to cause inflammation than high PaO2. Additionally, it is also supportive that inflammatory biomarkers were negatively correlated with PaO2, whereas positively correlated with FiO2. In conclusion, our study shows that hyperoxemia had a lower mortality than normoxemia in the entire ICU population, and high FiO2 levels were shown to be potentially more harmful than high PaO2 levels. But anyway, further RCT studies are required to determine the relationship between oxygen and patient's outcome. So thank you for your attention. Dr.
Thank you, Ayu, for your presentation. Before some questions come from I would like to ask you, how many patients did you include in the series?
About 942 patients.
Yes. And then perhaps an explanation may be just so simple. Patients who need higher FiO2 are more sicker, are sicker than other patients, reflecting that they have worse respiratory function. And the opposite, patients that are more sensitive for oxygen to have hyperoxemia, perhaps are reflecting they are in a better pulmonary function. It would be an explanation.
Yes, it is biggest our limitation. So to compare them, as I mentioned in the presentation, it is just only result of treatment, the possibility of result of treatments. It's not strategy. So yes, it is very good or big limitation. Yes, sir.
Thank you, Ayu. I mean, the question is a bit along the same. The same question is: have you tried to look at patients with high FiO2, high normoxia, high FiO2, hyperoxia, low FiO2? I mean, normal FiO2. I mean, to split the patient into 4 groups based on FiO2 and PaO2 at the same time.
I'm sorry.
Do you want it in French?
Yeah, I think it gives ideas for you to analyze PaO2 and FiO2 in circles. I see. Yeah, another question there.
A moment. Wait for.
It's a provocative results, but Ayu needs your help, guys, to understand. Yeah.
Thank you very much.
Thank you.
Oxygen is one of the most used medicines in the hospital, and we still don't know what to do with it. So your results are very interesting, but it confuses me. What should we do outside the ICU? Do you think oxygen is safe? Because you didn't measure oxidative stress parameters, right? You only measure infectious parameters. We know that even in myocardial infarction, when you give oxygen, there seems to be a higher mortality in some patients. So what do you advise us? Should we give oxygen uncontrollably, or?
And maybe you can help. What kind of stress parameters would you measure in the plasma?
Peroxynitrite, and there are some markers of oxidative stress, also DNA markers of oxidative stress you can measure, but their half-life is very low, so it's very difficult to measure them.
Very
we all
short.
talk about it, but we measure the infectious parameters. So I wonder whether that's the correct measurement.
About the biomarkers, of course, we tried to analyze the how can I say, other biomarkers in frog ICU. However, firstly, in previous studies, IL-6 is mainly mentioned as inflammatory biomarkers to explain the correlation, association relationship between the damage and the PaO oxygen. So we tried to focus on the IR6, and other reasons is technical one, because due to lacking of the number of patients in our database, we focused on these 3 inflammatory biomarkers. So further study, we have to try to for example, database or other biomarkers to explain the relationship.
Thank you very much.
Thank you.
Okay, thank you, Ayu. We have more questions, but no time for them.